Good afternoon to everyone. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome everyone to our webinar series entitled The Medical and Public Health Considerations of COVID-19. Today we have a very special webinar and very timely on the testing and treatment of 2020-2021 seasonal influenza during the COVID-19 pandemic. Next slide. I'd like to thank our webinar series partners for helping to spread the word about our webinar series. Much appreciated. Next slide. This webinar will be recorded and placed on the ACMT website and under our COVID response section, and everyone will get an email probably on Monday or Tuesday once the webinar is posted. Our previous webinars which we've run practically every week since March, are also up on the webinar and available for on-demand viewing. Next slide. There will be a Q&A after the conclusion of the talk. We'll probably have some 15 to 20 minutes or so for the Q&A. And so please type in your questions onto the Q&A box on the Zoom panel or the chat box, or if you're listening to it on YouTube, you can chat it into the chat box on YouTube as well. And we'll try to get to as many of your questions as possible. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle East and North Africa Clinical Toxicology Association. He's also an associate professor in emergency medicine and medical toxicology at Emory University. And Dr. Kazi will introduce our guest moderator and our featured speaker. Dr. Kazi.
Thank you, Dr. Wax. Hello, everyone. It's my pleasure to welcome our guest moderator, Ms. Sue Lever, who's actually a registered nurse and is a member of the Mercy Nursing Association, who is one of our series partners. And she's actually worked on the topic of influenza vaccination as it relates to the role of nurses, and participated in the authorship of a position statement in 2018 about the responsibility of emergency nurses in encouraging and administering vaccination in the emergency department. Certainly very important to encourage our patients to get vaccinated, and the role of nurses, emergency nurses in this area is critical. Ms. Lever is currently in Covenant Health, Knoxville, Tennessee, as a clinical practice specialist, and she will moderate the Q&A. Next slide. Our guest speaker is actually from CDC, Dr. Tim Uwecki. Dr. Tim Uwecki's title of his presentation is Testing and Treatment of 2020-2021 Seasonal Influenza During the COVID-19 Pandemic. I've had an opportunity to preview his slides, and I promise you a lot of information, very useful, practical information for any provider and public health professional in the US and around the world as well. Dr. Uwecki is the Chief Medical Officer of the Influenza Division at the National Center for Immunization and Respiratory Diseases at the CDC. And again, he has a wealth of experience in this area, and we look forward to his presentation. Dr. Uwecki.
Thanks very much, Dr. Kazi, and thanks to Dr. Wax and to Sue. Next slide, please. So what I'm going to talk about, this is kind of an overview. I'll talk about recent influenza activity, the issues about co-circulation of SARS-CoV-2 and influenza viruses. I'll go over influenza tests that are FDA cleared, as well as multiplex assays that detect SARS-CoV-2 and influenza A and B viruses that have received FDA emergency use authorization. Talk about antiviral medications for treatment of influenza and current influenza testing and antiviral treatment recommendations. Next slide, please. So what I'd like to do is start with going over what happened earlier this year. This is the 2019-2020 influenza season. And what you can see is that the influenza season peaked really in late February and then sharply declined there. And it's a sharper decline in the solid line, the 2019-2020 season, than prior seasons that you can see. And you can see where the arrow where nationally the COVID-19 public health emergency was declared, and then a huge drop off. So there was a decrease in specimens that were tested for influenza from outpatients, but those that were tested, there was a 98% decrease in the number testing positive. And it's thought that this decline is probably mostly due to the implementation of COVID-19 community mitigation measures. It is true that fewer people left home to seek medical care, but we've noticed very, very low influenza activity in the US and currently. Next slide. So one question is, what else happened in other parts of the world? So if you can look at the top left, in China, the same thing happened. In the red, you can see the 2019-2020 season with a much sharper drop than compared to 2017-18 and 2018-19 seasons. And then below that is data from Taiwan. Similar finding if you look in the orange, the lighter shade and the darker shade, influenza A and B, really dropped off, looks like about the end of February, compared to the previous season, which is in blue, where you see that influenza viruses continue to be detected. And then if you look at the bottom left-hand slide, this is more severe cases, the same thing. It's not all cases, it's all cases, including severe cases, really dropped off. Then on the right side, this is data from Singapore. Similarly, the 2019-2020 season in red compared to the prior season, average in green, and you can see the fainter data lines from other seasons. But in terms of clinic visits, we see that plummeted in box A. In box B, a number of people tested also plummeted, but you can see then C that and D, so the percent positivity of those that were tested really, really dropped, and similarly the number of influenza cases really dropped. So this really did show all these three countries in Asia a big decline in influenza activity earlier this year with the first wave of the pandemic and control measures being implemented. Next slide. So then the question is, well, what about in the Southern Hemisphere? So in their winter, which is our season, so they've completed their winter influenza season. In fact, they had very, very low, almost no influenza activity compared to what they would expect. So this is data from here from Australia. And what you typically would expect, if you look at the dashed line, which is the 2019 season, compared to really the 2020 in the solid line, which is essentially mirrors the zero line. So the 2020 positivity was close to zero, big, big drop off. And that's associated with all these public health interventions that were implemented. Next slide. So another country in the Southern Hemisphere in South America, similar kind of thing. They would typically experience influenza their winter season, but in fact, compared to 2019, you see the dashed line, sort of the typical expected season, and also prior seasons to that. And the 2020 season, which also mirrors that 0% positivity, very, very little influenza activity. Next slide. And finally, here's South Africa, similar kind of thing. If you look at the dashed lines, these are from prior seasons compared to the very, very bottom line, which is the 20% positivity, it's close to zero. So almost no influenza activity in these three countries in the Southern Hemisphere, and most likely associated with both reduction in people seeking outpatient care, so a huge reduction in specimens. But then of those that did seek care, a very low percent that were positive, and so much lower than was expected. And this is all thought to be because of community mitigation efforts to control the COVID-19 pandemic. Next slide. So what are the implications and what's going on more recently? So as I've mentioned, influenza activity seems to decline with the implementation of SARS-CoV-2 control measures. So those communities that are really doing a good job with comprehensive mitigation measures, with high compliance, particularly with face mask wearing and social distancing, across the US, those might experience low influenza activity. But it's pretty clear that a lot of communities in the US, we're seeing a huge surge in SARS-CoV-2 activity right now in transmission. So we certainly could see influenza activity starting up in communities where there isn't much implementation of SARS-CoV-2 control measures. And then most recently, over the last few months and currently, there is influenza activity in South Asia and Southeast Asia. And in particular, it's influenza A H3N2 viruses that are circulating. And H3N2 viruses are associated with more severe influenza epidemics than other kinds of influenza viruses, influenza B or influenza AH1N1, PDM09 viruses. So this is a concern. And in particular, there's been an increase in influenza activity in Bangladesh, and now more recently into India, as well as Cambodia, Laos, and more recently into Thailand. So we don't know what this means. There is potential to spread regionally in Asia, but there's also potential to spread to other areas of the globe through air travel. And so therefore, what's really pretty critical is to monitor is viral surveillance. And it's not just SARS-CoV-2, and it's not just influenza viruses, but it's all respiratory viruses. So it's going to be important for clinicians and public health to really monitor surveillance data at the local level, the state level, and national level. But it's also important to look at the findings from clinical laboratories and hospital virology laboratories to really get a handle on what's going on locally in your community. And I do think that while influenza activity overall is quite low in the US right now, we have no choice, but we need to prepare for co-circulation of influenza viruses and SARS-CoV-2, and that this could be increasing in the weeks to months to come. And therefore, we need to focus on prevention control strategies for both SARS-CoV-2 and influenza viruses. And it's likely that the reason why influenza activity has really gone down in areas that have implemented SARS-CoV-2 control measures is because influenza viruses are not as transmissible as SARS-CoV-2 is. In addition, most transmission with influenza viruses, we believe, is from symptomatic persons. So wearing masks for source control and then wearing face masks to prevent exposure is going to help prevent both SARS-CoV-2 and influenza virus transmission. Next slide. So co-circulation, what do we know about co-circulation and really about co-infection? We know that co-infection can occur with influenza A or B viruses and SARS-CoV-2. There are a number of case reports, small case series, some medium-sized case series. What we don't know is the frequency, the severity, and the risk factors for co-infection. There are some reports that do suggest higher severity of disease, of respiratory disease, when you have co-infection with influenza viruses and SARS-CoV-2 compared to influenza alone or COVID-19 alone. One of the big challenges for the clinical community is that with influenza versus COVID-19, there are overlapping signs, symptoms. There are some differences. The incubation period for influenza virus infection is much shorter, 1 to 3 days, 1 to 4 days, typically 2 to 3. Then for SARS-CoV-2 infection until you're symptomatic with COVID-19, which is really a median of about 5 days, range of 2 to 14 days, so longer incubation period for COVID-19. And then viral shedding and the period of viral RNA detection is generally shorter for influenza. The loss of taste, the loss of smell, or abnormalities with taste or smell are more common with COVID-19 than influenza. It's not, if you have the loss of taste or loss of smell, it doesn't automatically mean you have COVID-19. It has been reported with influenza as well as other respiratory viruses, but loss of taste or smell is much, much more common than with COVID-19 than other respiratory virus infections. We know that diarrhea can occur in young children with influenza, but it can occur at any age with COVID-19. And the timing of the onset of complications, progression to severe disease is earlier with influenza, typically in the first week after illness onset, whereas with COVID-19, progression to severe disease is typically in the second week or late in the first week, and also spilling over even into the third week after illness onset. We know that the high-risk groups for severe complications are very similar. One group that is not thought to be at high risk for severe disease with COVID-19 are young children, but young children are clearly at high risk for influenza complications that might lead up to hospitalization. So because of the overlapping signs, symptoms, so forth, complications, you really need to test in order to distinguish influenza from COVID-19. And you also need to consider either influenza virus infection or SARS-CoV-2 infection alone, as well as co-infection.
We appear to have lost audio with Dr. Uyeki. If you'll hold one moment, we'll work on getting him back online. One moment, please.
This is a good time for you to maybe enter some questions in the Q&A box while we get Dr. Uyeki back online. It's interesting, Dr. Wax, what Dr. Uyeki is pointing out in terms of what's going to happen to our influenza season in the US based on the experience we have from the Southern Hemisphere.
Yes, no, I totally agree. I mean, his data that he's presented so far is quite striking, I think, in the almost zero prevalence of influenza in the Southern Hemisphere.
Dr. Uyeki, are you back online now? I think I can hear your audio. If you want to go ahead and unmute yourself. And would you like to try speaking again? We appear to not be able to hear you again, so you might try working on your audio once more. I'm sorry, Paul, I didn't mean to interrupt you, Dr. Wax and Dr. Kazi.
No, please do. Anytime Dr. Uweki is back, please interrupt us and we can resume the webinar. But I thought, it's important to remind ourselves that influenza may still show up in our emergency department. And if we don't test for it, we will probably not detect it and ascribe everything to COVID. I recently saw the influenza test option in my order set in my electronic medical record. And I was, really focusing on patient care and who has COVID, who doesn't. And I saw the influenza button and I thought about clicking it as well. And I would ask Dr. Uweki when he gets back about the potential impact of me ordering that test on the general resources in terms of reagents and equipment that we need to get these tests done. Because I remember I just did not click it in that case. Yes, Dr. Uweki. We just heard you for a second. Yeah, I think you're back. Welcome back.
Okay, sorry about that. I don't quite know what happened, but I'm calling in by cell phone. So
you sound great, and you feel free to pick up where you stopped, and we'll be fine.
Okay.
Thank you.
My apologies to the audience. I'm not quite sure what happened, but okay. So I'll just start again for talking about influenza tests. So there are a variety of influenza tests that are available to clinicians to detect influenza viruses in respiratory specimens. They differ by the time to produce results, what kind of information is provided, what respiratory tract specimens are approved, typically upper respiratory tract specimens. There are differences in the approved clinical settings, and there are clearly differences in the accuracy. So most people are probably familiar with the rapid influenza antigen detection tests. These are FDA cleared, they're singleplex. There's also multiplex assays. And recently, FDA did issue an emergency use authorization for a multiplex assay that detects SARS-CoV-2 and influenza A and B viruses, which is an antigen detection assay. But there are also a variety of nucleic acid detection or molecular assays, including both singleplex and multiplex assays. And this was all before the COVID-19 pandemic. But now there are at least 9 multiplex assays that detect SARS-CoV-2 and influenza A and B viruses with high sensitivity and high specificity that have received FDA EUA. And overall, no question about it, nucleic acid detection tests have much higher sensitivity than the antigen detection or the rapid antigen tests that are used in a lot of ambulatory settings and in some emergency rooms as well. So there are a variety of point of care assays that are CLIA waived, can be used at the bedside, can be used in the clinic. But there are also assays that are for moderately complex settings, and that requires a clinical laboratory. So you have to send a specimen to the clinical laboratory. There are also assays that are categorized as highly complex, and they require large clinical laboratories or sophisticated public health labs. Next slide, please. So this is a table of the FDA cleared tests that detect influenza viruses and respiratory specimens. This is all before the COVID-19 pandemic. And so the antigen detection tests are the rapid influenza diagnostic tests as well as immunofluorescence assays. Then there are molecular assays, which are nucleic acid detection assays, the rapid molecular assays. There are also other molecular assays that are for hospitalized patients. And there are differences in the time to results. So most people in ambulatory settings like the rapid influenza tests because you get a result in 10 to 15 minutes. That's the great advantage of those tests. The downside is the sensitivity is not as good as molecular assays. There are some rapid molecular assays that do yield a pretty timely result, 15 to 30 minutes. Other molecular assays take more than 30 minutes, 45 minutes, up to 8 hours. Then there are these multiplex molecular respiratory panels. that do detect a range of different viruses, as well as some bacterial targets that pick up influenza viruses. Next slide. And as I mentioned, FDA has issued some emergency use authorizations for multiplex assays that detect influenza viruses and SARS-CoV-2 in respiratory specimens. So all of these depicted on this slot in this table are nucleic acid detection assays or molecular assays with high sensitivity, high specificity. There is one that's an antigen detection multiplex assay that's listed as second from the bottom there. And you can see the range and result time. The top four assays that are listed do detect many, many different respiratory viruses, not just influenza A and B and SARS-CoV-2. So this is just to let you know there are many different manufacturers, many different kinds of tests that are authorized by FDA under emergency use authorization that can be used to detect influenza A, B, as well as SARS-CoV-2 in respiratory tract specimens. Next slide. So what tests are recommended in the outpatient setting? The Infectious Diseases Society of America, the IDSA, do recommend that rapid influenza molecular assays are recommended over the rapid antigen detection tests, and that's because of the much higher sensitivity of the molecular assays. It is pretty clear that throughout the U.S., most ambulatory care settings, if they're using influenza tests, do use the rapid test. So if you have the ability to have access to the molecular assays, you want to use them. If you don't, then go ahead and use the rapid antigen tests. But you do need to realize that when there's a lot of influenza activity, you can get false negative results. So you need to be able to interpret a negative result. And of course, now in the low prevalence situation, you need to be cognizant of how to interpret a positive result, because a positive result this time of the year, when there's very low influenza activity, could be a false positive result. For hospitalized patients, IDSA recommends molecular assays, and that could also be these multiplex assays that I mentioned that detect SARS-CoV-2 and influenza viruses. For hospitalized patients, rapid antigen detection tests, immunofluorescence assays should not be used unless molecular assays are not available. For immunocompromised patients, because they can experience viral pneumonia with many different respiratory viruses as well as bacterial pathogens. So multiplex assays that target many more pathogens are recommended, not just looking at influenza A and B and SARS-CoV-2. I just want to alert clinicians, don't order viral culture for the initial or primary diagnosis of influenza. It's not going to yield timely results. It's going to be 3 days minimum to a result. It's useful for public health, but not to inform clinical management. Similarly, do not order serology for influenza. Some of the large commercial laboratories do offer influenza serology. Do not order this because results from a single serum specimen are uninterpretable. You really need to collect paired, acute, and convalescent sera 2 to 3 weeks apart, and you need to have that serology done at specialized public health laboratories. So serology and viral culture is not going to inform clinical management of influenza. Next slide. So who should be tested during influenza season? So hospitalized patients with acute respiratory illness with or without fever, including patients with pneumonia, patients who have exacerbation of COPD, other chronic cardiopulmonary disease, including heart failure, immunocompromised high-risk patients with acute onset of respiratory symptoms, anyone who is hospitalized who then develops acute onset of respiratory symptoms with or without fever, without a clear diagnosis because of the potential for nosocomial influenza. In the outpatient setting, we really say that test if the results will influence clinical management. And the reason is that you can make a clinical diagnosis of influenza based upon local influenza activity, history of the patient, signs and symptoms of the patient, your exam, without doing influenza testing. And we want to really focus high-risk patients, particularly those who have progressive disease, pneumonia, but are not being admitted, people from congregate settings. So test if those results are going to influence clinical management, decisions to give antiviral treatment or not, decisions to give antibiotics or not, yes or no, which might be influenced by an influenza test. The reason to test someone from a congregate setting is if you're returning them to a setting, they don't need to be admitted to a hospital, but if they have influenza, that's really important for the congregate setting. For other, that person needs to be isolated away from others in that setting. So the other thing is that influenza can exacerbate underlying chronic medical conditions. So even if they don't have classic influenza-like illness or known complications, if influenza viruses are circulating, think about exacerbation of chronic conditions with influenza. Now, just to point out that history of influenza vaccination does not exclude a diagnosis of influenza, unfortunately, because of the moderate effectiveness of influenza vaccines. Okay, better than not being vaccinated, but unfortunately, some people who are vaccinated can still develop influenza. So history of vaccination does not exclude a diagnosis of influenza. And people who are not at high risk for complications of influenza, you can test them if the results might change clinical management. Next slide. So just want to point out a couple things. So in terms of the upper respiratory tract, influenza viruses typically can be detected for about 3 to 4 days by antigen detection assays and about 5 to 6 days by molecular assays in people who have uncomplicated mild illness. However, viruses can be detected longer in young infants and in people who are immunosuppressed. The best yield is from the nasopharynx, typically collected within the first 3 to 4 days after illness onset, but you really should check the approved clinical specimens for the influenza test that you have, because some are for nasal swabs or can use combined nasal and throat swabs. A throat swab alone is going to have the lowest yield for influenza viruses. People who are more severely ill are going to have longer detection of influenza viruses, and then patients on corticosteroids or treated with corticosteroids and those who are immunosuppressed have longer viral shedding. Patients who are hospitalized, so if you're seeing in the emergency room someone who's got pneumonia, is pretty sick, who's going to be hospitalized, if you just sample the upper respiratory tract and those people have been sick for, say, 5, 6, 7 days, they might have cleared influenza viruses in the upper respiratory tract, but they may have ongoing or prolonged viral replication in the lower respiratory tract. We know from the pandemic in 2009, there were critically ill patients who were negative by RT-PCR in the upper respiratory tract, but the diagnosis was made by sampling the lower respiratory tract. And this also includes patients who are negative by endotracheal aspirate specimens, and the diagnosis was made by a bronchoalveolar lavage specimen. Next slide. So in terms of approved antivirals, there are 4 approved antivirals for treatment of influenza that we do recommend. These include the class of the neuraminidase inhibitors, which are oral oseltamivir, inhaled zanamivir, and intravenous peramivir, and also includes the class more recently since 2018, the cap-dependent endonuclease inhibitor baloxavir, which is an oral drug. The advantage of that drug, it's approved for patients, for early treatment of patients 12 years and older, is that is a single dose. The oseltamivir is 5 days twice daily. Zanamivir is 5 days twice daily. Peramivir is a single IV dose in the outpatient setting. So all of these have been shown to have efficacy for early treatment of influenza less than 2 days within 2 days of illness onset in patients with uncomplicated influenza in the outpatient setting compared to placebo. There are differences, not only, as I mentioned, in the route of administration, but also in the approved ages for treatment. Next slide. So we do want to really focus on patients who are at the highest risk for influenza complications, and we want to intervene early with antiviral treatment if possible. So just to go over these groups, it's young children, particularly less than 2 years old, although we consider children less than 5 years old at high risk for complications. The highest hospitalization rates and the highest mortality rates are in those less than 2 years old. Adults 65 years and older, pregnant women or those postpartum out to 2 weeks after delivery, American Indians and Alaska Natives, children less than 19 years old who are receiving long-term aspirin therapy, people with underlying medical conditions, chronic conditions, pulmonary, cardiac, immunosuppression, neurologic and neurodevelopmental conditions, persons with a body mass index of 40 or greater, residents of nursing homes and chronic care facilities. Next slide. And so our antiviral treatment recommendations, we really prioritize on early treatment of people with severe disease and those who are at high risk of severe disease. And so we do recommend initiating antiviral treatment as soon as possible for any patient with confirmed or suspected influenza who's hospitalized, and that includes without waiting for testing results, outpatients with complicated or progressive illness of any duration, so including more than 2 days after illness onset, and outpatients who are at high risk for influenza complications. For people who are otherwise healthy, who are not at high risk of complications of influenza, who present with mild disease, if they present within the first 2 days after illness onset, we say, clinical judgment, you can treat them. Clearly, they can benefit versus that's been shown in placebo-controlled trials. There can be a reduction in the duration of their illness, but they'll also likely recover without treatment because they are not at high risk. And non-high-risk people who present more than 2 days after illness onset probably are not going to benefit from antiviral treatment here. It's those that have more severe disease and who are at high risk, those people can benefit. Next slide. So for hospitalized patients, again, oseltamivir is recommended, and that's either oral or for patients who are intubated, it can be enterically administered through an oral gastric or nasogastric tube. We know that there are observational studies that have reported that starting neuraminidase inhibitor treatment within 6 hours of admission or at admission was associated with shorter duration of hospitalization, and that's why we recommend start treatment without waiting for testing results. We do know that patients being admitted from the emergency room, say at night, maybe the test results not back, they get to the floor, the hospitalists or those in the ICU are very busy, and it's not till the morning they see the test result and then antiviral treatment is started. So we want to start treatment if influenza is suspected without waiting for testing results because things can fall through the cracks and because of a couple of observational studies that have shown benefit when you start treatment right at the time of admission or shortly thereafter compared to later initiation of treatment. We do not recommend inhaled zanamivir, and we do not recommend oral baloxavir in hospitalized patients because of the lack of data in hospitalized influenza patients. Although there is insufficient data for paramivir, because it's an intravenous drug, is an option for patients who cannot tolerate or absorb enterically administered oseltamivir. So patients with gastric stasis, malabsorption, gastrointestinal bleeding, that may be an option.
but we really need more data. We don't know the optimal duration of oseltamivir treatment for critically ill patients. Next slide. So outpatients, again, for those with complications or progressive disease, regardless of duration, we do recommend oral oseltamivir treatment as soon as possible. For patients with suspected or confirmed influenza, so with mild disease or uncomplicated disease, you can select either oral oseltamivir, inhaled zanamivir, IV peramivir, or oral baloxavir for early treatment. Depending upon approved age groups and contraindications, they're probably all equivalent, except for treatment of influenza B. There is one randomized controlled trial that did show, it's published earlier this year, it showed that baloxavir had greater efficacy compared with oseltamivir in persons aged 12 and older who had influenza B. And then for those who have uncomplicated disease, who are non-high risk, as I mentioned, they present early based upon clinical judgment, they can be prescribed antiviral treatment, including through telemedicine. However, if they have underlying high-risk conditions, they probably need to be evaluated in person. And in addition, because influenza-like illness, acute respiratory illness, these are syndromes. They're not specific for influenza. They're not specific for SARS-CoV-2 infection either. However, there's no doubt during the COVID-19 pandemic, you need to consider SARS-CoV-2 pretty high, if not at the top of the differential. And if influenza viruses are co-circulating in the local community, then you need to think about influenza virus infections, but you also need to think about other respiratory pathogens. Next slide. So special groups, just to mention, for pregnant women, we do recommend oral oseltamivir. If influenza is suspected or confirmed, we do not recommend baloxavir because there's no data, safety or efficacy data for baloxavir in pregnant or lactating women. For immunocompromised patients, we also recommend neuraminidase inhibitor treatment, typically oseltamivir. We do not recommend baloxavir treatment. It's only a single dose, and we are concerned about the emergence of baloxavir resistance and then potential transmission to close contacts. We do need studies to look at combination antiviral treatment with both neuraminidase inhibitors and baloxavir, however. So that's probably a group, particularly those who are severely immunocompromised, so your hemopoietic stem cell transplant recipients or solid organ transplant recipients, that you might want to consult an infectious diseases specialist, particularly someone who specializes in transplant infectious diseases, about guidance on antiviral treatment for those patients with influenza. Next slide. So just a couple other things about co-circulation of influenza viruses and SARS-CoV-2. The FDA-approved antiviral treatments for influenza do not have any effect on COVID-19. Oseltamivir and baloxavir have no in vitro activity against SARS-CoV-2, and there are also no drug interactions with remdesivir. We know that patients being admitted with more severe disease with COVID-19 are being treated with dexamethasone. That's pretty much standard of care now. However, corticosteroids, including dexamethasone, can prolong influenza viral replication. So that is something to be considered. And there really is conflicting observational study findings about corticosteroids and influenza mortality. High-dose corticosteroids probably are associated with mortality in influenza patients. We need more data about low dose or moderate dose corticosteroids. Another thing just to mention is that community-acquired bacterial co-infection appears to be much more common with influenza than with COVID-19, although data are limited and not really, we don't have good direct comparisons, but we know that community-acquired bacterial co-infection is a common complication of patients with influenza who are being admitted to the hospital, including to the ICU. And the typical bacterial pathogens we worry about with influenza co-infection are methicillin-resistant or methicillin-sensitive Staph aureus, as well as Streptococcus pneumoniae and Group A strep. Now, community-acquired bacterial co-infection can occur with COVID-19, and so it's not that it doesn't occur, but it's much more common with influenza, at least from the limited data available to date. Next slide. And what I want to show in the last few slides here is just some resources. So on the CDC influenza testing web pages, we have posted some new clinical algorithms. You can see in the red box in the upper left-hand corner here, testing and treatment of influenza when SARS-CoV-2 and influenza viruses are co-circulating in your local community. We have guidance. We have 3 clinical algorithms. One is a consolidated one, both for patients being admitted as well as those not being admitted. We have one just for outpatients, and then we have one for patients being admitted from the emergency department to the hospital. And then the fourth one down there is guidance in long-term care facilities for outbreaks where SARS-CoV-2 as well as influenza viruses are suspected. And then on the right side, under the yellow box there, we have information about influenza tests, and then I just highlight in the light blue there, Table 4, multiplex assays authorized for simultaneous detection of influenza viruses and SARS-CoV-2 by FDA emergency use authorization. So you can just put in Google CDC influenza testing and you'll bring up this web page. Next slide. And so this just shows you that consolidated clinical algorithm that I mentioned. It's just some guidance about testing for SARS-CoV-2 and influenza viruses, and also treatment for influenza. Next slide. So this one is just the part for patients who don't require hospital admission. Next slide. And this is the same algorithm, but for patients requiring hospital admission. So these are all accessible on the CDC web pages, influenza testing web pages. Next slide. And I think those clinical algorithms, they can be used by emergency physicians, or they can be adapted. You can take them, you can tweak it as your hospital or you and your colleagues think is best for your setting. And then just to let clinicians know that we do have updated guidance on antiviral medications, antiviral treatment for influenza for clinicians. Again, you can get there by just putting in Google CDC influenza antiviral medications or antiviral treatment. You can bring this up. And next slide, please. And we do have a section on those antiviral web pages, co-circulation of influenza viruses and SARS-CoV-2. And this kind of goes over the recommendations that I also mentioned. Next slide. So in summary, just to say that our influenza testing and treatment recommendations when influenza viruses are circulating in the community are pretty similar to those before the emergence of SARS-CoV-2 causing the COVID-19 pandemic. We do emphasize that molecular assays are recommended for patients being hospitalized. They're also recommended, particularly the rapid molecular assays for outpatients during influenza season. We do recommend antiviral treatment with OSELTAMIVIR as soon as possible for hospitalized patients with suspected influenza without waiting for influenza testing results. And we do recommend antiviral treatment as soon as possible for outpatients with suspected or confirmed influenza who have progressive disease, regardless of illness duration, as well as persons at high risk for influenza complications. And you can make a clinical diagnosis of influenza and then treat the patient empirically, or you can use influenza testing to help guide your management. But please be careful about interpreting both a positive and a negative test. A positive test certainly can be used to justify prescribing antiviral treatment for influenza if you can get timely results on site. And then, you know, if in your local community, if influenza activity is being detected, you have to consider the possibility of either influenza virus infection alone, SARS-CoV-2 infection alone, or both influenza and SARS-CoV-2 co-infection in patients presenting with acute respiratory illness with or without fever. Next slide. So thanks very much. My sincere apologies for whatever audio glitches occurred there. I'm glad you can hear me from switching over to my phone, and I'll be happy to take some questions in the remaining time.
Dr. Wicki, thank you so much. This was an excellent presentation. You shared a wealth of information that is very useful to every single one of us today. I want to ask you before Ms. Lever starts the Q&A, would you be able to stay online another 10, 15 minutes if we need to? Because we have a lot of questions in the queue.
Yes, no problem.
Thank you. Ms. Lever, would you like to go ahead and start the Q&A and turn it over to Dr. Wax and I later on? Thank you.
Yes, I would. We have quite a few questions here. And with the 2020 positivity rate being close to 0 in the Southern Hemisphere, is it possible that they're just not testing for it and they're focusing on COVID instead?
Yeah, thanks for that question. So we do know that a lot of countries around the world certainly prioritize testing for SARS-CoV-2 because of the COVID-19 pandemic, and deprioritize other respiratory virus testing. We also know that there was respiratory virus testing going on, including for influenza viruses, but that a lot less specimens were tested. But as I mentioned, that clearly there were specimens, respiratory specimens that were tested, including in the Southern Hemisphere, and the percent positivity was extremely low. So it appears to be a real finding. And, you know, in the US, I can say for last season, you know, we were certainly testing for influenza viruses, and we saw a huge drop once the pandemic was declared at the beginning of March, and a lot of public health interventions were implemented. And I can say for this season that public health laboratories are running the CDC real-time RT-PCR assay, which is a molecular assay that detects influenza A and B and SARS-CoV-2. And so all respiratory specimens going to public health labs are being tested for influenza viruses as well as SARS-CoV-2. We're also getting data from clinical labs that are using commercial assays. So I think the findings of the Southern Hemisphere were real. And we also know that in Southeast Asia and South Asia, as I mentioned, influenza surveillance, public health surveillance is picking up influenza A, H3N2 virus activity, as well as some of the clinical labs are picking up. So influenza viruses have not disappeared, but it's really hard to know what's going to happen in the U.S. this season. My best guess is it's going to be quite variable across the U.S., and some communities are going to experience influenza activity. So I think we are going to have co-infections, but we'll also have just some influenza virus infections alone. And, you know, when that's going to happen, we don't know. But I think we just all need to keep up with, you know, the latest updates. And each week on Fridays, the influenza division at CDC posts a weekly surveillance update on influenza. Of course, there's also updates for COVIDnet about SARS-CoV-2 detections, but stay tuned. Thanks.
Thank you. Someone else has asked, when do you actually recommend starting to test for both viruses? Do we just wait until we see that the flu is circulating, or we're concerned about limited resources?
Yeah, it's a great question. I think there's a lot of things to be taken into account. The limited resources is one, and by resources, that's swabs, that's reagents, so forth, and tests. The other issue is if you test a lot and there's hardly any influenza activity, even with molecular assays, there is the potential for some false positive results. So what clinicians probably should do is pay close attention to local public health surveillance as well as your state's public health surveillance, and then just see, because there is clearly there are commercially available assays. See what those tests are yielding. But I can tell you that some hospitals are holding off testing just because influenza activity is so low. I think that in hospitalized patients, it's not a bad idea to test, but you do need to really interpret results pretty carefully. So if I were to say, yeah, go ahead and test everyone now, when influenza activity is quite low, that is obviously going to drain your testing resources. So I think it's the most important thing I would say is stay tuned very closely to what is going on with your state public health surveillance for influenza, as well as SARS-CoV-2. And then if there is local public health surveillance data and any other kind of hospital laboratory testing for influenza that's going on, pay attention to that. And then when these indicators start going up, that's the time to start doing a lot more testing. And it's I don't think there's a right or wrong answer here, but I think at this time right now, influenza activity is quite low across the U.S.
Okay, thank you. Here's a question on, is there any evidence, have we seen anything where the adjuvant in the influenza vaccine can make the cytokine reaction worse with the SARS-CoV-2?
That's a pretty interesting question. So adjuvanted vaccines for influenza the issue for people 65 years and older is that in general, vaccines are less immunogenic and they're less effective for older adults. And so we know from influenza vaccine studies that people don't mount a good antibody response with standard dose influenza vaccine. And so two strategies that have been developed and frankly approved to improve the immune response in people 65 years and older to influenza vaccines are, one, to use higher dose, so a higher concentration of vaccine virus antigens. So there's the high dose influenza vaccine, which is 4 times the concentration of each antigen compared to standard dose vaccine, or adjuvanted vaccine. So it's standard dose, but it's an adjuvanted vaccine. And the idea there is the adjuvant will improve the immunogenicity. You'll develop a better immune response, and therefore will hopefully result in higher vaccine effectiveness. So those are two strategies that have been developed and in fact approved vaccines, adjuvanted vaccines, as well as high dose vaccines for people 65 years and older. So I think the question is getting at, in a patient who has COVID-19 and you vaccinate them with an adjuvanted influenza vaccine, they're 65 years or older, will that worsen their COVID-19 disease? And so the way I would answer that is to say that CDC has developed guidance for influenza vaccination of patients with exposure to someone with COVID-19, patients with asymptomatic or pre-symptomatic SARS-CoV-2 infection, and then here we're talking about a patient who's symptomatic with COVID-19. So in general, for someone who's symptomatic with COVID-19, the recommendation is that we should consider postponing influenza vaccination for at least 10 days after symptom onset and 24 hours without fever, without the use of fever-reducing medications. and improvement overall in COVID-19 symptoms before you vaccinate them with influenza. The other thing is, you should not vaccinate someone who has moderate or severe illness with COVID-19 with influenza vaccination. You should wait till they're recovered from their COVID-19 illness before you vaccinate them. So the other reason to defer vaccination of someone with COVID-19 for at least 10 days, and then they should have improved, is because you don't want to expose the vaccinator. You want to reduce the chance of transmission to the vaccinator. Obviously, they need to be protected with personal protective equipment. But the issue of even if you were to give an adjuvanted vaccine to someone with COVID-19, that's a very good question. I don't think there are any data on what that might do to the person's COVID-19 illness, but that is another reason to wait until a person has recovered, because of, some people, it's a minority of people, but will mount a fever with influenza vaccination. The most common adverse event is pain. But if you get a fever, the question is that a fever because of the vaccine, or is that a fever because of worsening of their COVID-19 illness? So anyways, go to the CDC guidance on our web pages, put in CDC COVID-19 vaccination or influenza vaccination. You can pull up, we updated that guidance, I think, earlier this month.
Thank you. It just leads right into another question here. Do we know if there's any concerns or any evidence about whether or not we should administer the flu vaccine and the SARS-CoV-2 vaccine? How close together we could administer those?
That is an excellent question for which I know of no data to guide that. And so what I would say is right now, patients, people, you don't have to be sick. So people, anyone aged 6 months and older in the US who has not received influenza vaccine for this season should get vaccinated now. There's a record number of doses available of influenza vaccine, projected to be 194 to 198 million doses. That's far more than we've ever had available. Already there's more than 180 million doses of influenza vaccine that have been distributed in the US. So there's vaccine out there. People should get vaccinated now. Now, we have heard that SARS-CoV-2 vaccines may start becoming available towards the end of this year and into January. And among those in the first tier are healthcare personnel. So I think that's a really good question about issues about co-administration of influenza vaccine and SARS-CoV-2 vaccine, for which I'm not aware there are any data. So I don't think I can answer that question. But what I would advise people is, especially healthcare personnel, get influenza vaccine now. Don't wait.
Yes, I definitely would agree with that. Here's a question on back to testing for the SARS-CoV-2. Is there any evidence or best practice for if you're holding a large scale training event or group gathering that's essential for public safety and say in the military, to have a pre-deployment negative tests, do the tests and conduct them so you have a baseline?
I think that, a lot of events, a lot of gatherings that are planned, people are requiring that, realize that is not a foolproof way to guarantee there's not going to be transmission at the event, because usually people are tested maybe 3 days before departure to the event, and in order to get the results in time. But it is possible during travel to acquire infection with SARS-CoV-2, as well as it depends on what test is being done. if you get an antigen test, although antigen detection tests for SARS-CoV-2 are really they're authorized by FDA for symptomatic people, and typically in the first 5 days after illness onset. Here you're talking about testing asymptomatic people, and you really need a molecular assay to have higher sensitivity. It may help give you some reassurance, but given right now in the U.S., there is a lot of SARS-CoV-2 transmission going on, and it's looking like this is only going to increase. So that won't eliminate the risk. And that's why a lot of public gatherings, a lot of events, particularly congregating indoors, are being canceled, deferred, postponed. If those events are taking place, then you really want to have social distancing. You want to have mask wearing indoors. You want to really reduce exposures as much as possible.
Okay, you may have answered this, but I just want to ask it to make sure. If a person has tested positive for COVID-19 but was asymptomatic, do we need to go ahead and get an antigen SARS-CoV-2 test to see whether or not they're still COVID-19 positive?
Once someone has a positive test, the recommendation is they need to be isolated for 10 days. Right. That's basically to reduce the risk of transmission to close contacts or to anyone else. And so you do not need to be retested if you test positive. You need to be isolated for 10 days. People who are retested after 10 days, they're likely to still be positive. Yeah. And so it's not really going to help. So the key thing is people, even if they're asymptomatic, they need to be isolated for 10 days. And the exception would be people who are severely immunocompromised, or even we'll just say immunocompromised, because they might potentially have more prolonged viral replication. And so those are people who might require isolation for longer periods and retesting as well. But the problem with retesting is it doesn't tell you about infectiousness. And we know that people can test positive for long periods of time, and it does not necessarily mean you're infectious. So 10 days of isolation, and then as long as you're not immunocompromised and you didn't become ill at all, then you're fine.
Okay, I think someone else is going to ask some questions, so I'm going to continue listening. This is fascinating.
It's been a pleasure. It's been a pleasure to hear Dr. Ueki answer these questions. What interesting questions this pandemic has created. Dr. Ueki, any experience from influenza vaccination campaigns that could apply to vaccine acceptance for the COVID-19 vaccine?
That's a great question. Unfortunately, we know that there are disparities with influenza vaccine, and particularly in minority populations in the U.S., and we need to overcome those disparities. And as we've seen from the COVID-19 pandemic, there's clearly, this is highlighting underlying disparities and health inequities. So I think that there needs to be special outreach to minority populations. We have seen that the highest infection rates are in American Indians, in African Americans, in the Latino community, and also these groups are at risk for complications as well. So I think special outreach needs to be done to reach minority populations. There are clearly a lot of, unfortunately, anti-vaxxers out there. There are people that are skeptical about these vaccine trials that have been going on. One of the biggest challenges, I think, is that in contrast to seasonal influenza vaccination, where you only need one dose, with the SARS-CoV-2 vaccines as they get rolled out. The ones that we've heard about, the Pfizer vaccine and the Moderna vaccines, these are 2-dose vaccines. And so what's really going to be important is people need to get the second dose, and it needs to be in the appropriate interval, and you need to get it with the same vaccine. You don't mix and match here. And so I think that's going to be logistically and operationally a nightmare to administrative nightmare to really record, and both for the individual being vaccinated as well as to keep track for vaccine registries and records. But the real nightmare is going to be maintaining the cold chain, because the Pfizer vaccine requires minus 80 degrees Celsius storage, deep freeze, whereas the Moderna vaccine is minus 20, or, that's a freezer. So there's going to be cold chain issues, but we know that there's a reluctance to get influenza vaccination. I think a lot of people believe that, or perceive influenza as not a severe disease. We know that influenza clearly is associated with a lot of hospitalizations and deaths every year, including in young kids. But COVID-19 has clearly killed, has resulted in more hospitalizations and more deaths than with seasonal influenza. And hopefully people will get vaccinated. So I think there are some lessons. Things are a little different. We have to deal with the rumor mill now, and I think it's just going to be clear messaging. But one thing that is going to be a little different is that I mentioned with these vaccines that require 2 doses, there's a fair frequency of febrile and systemic reactions with the second dose. In general, influenza vaccines, there's not many side effects. It's typically pain at the injection site. Not that many people actually get fever. However, with these SARS-CoV-2 vaccines with the second dose, a lot of people are going to get fever and headache and muscle aches and stuff. And it's going to be really a big challenge to differentiate that, particularly for healthcare personnel who are vaccinated, differentiate those vaccine-related, SARS-CoV-2 vaccine-related effects distinguish that from actually SARS-CoV-2 infection and COVID illness. So this is going to be a challenge for clinicians and public health moving forward. So there are some lessons, but there are also a lot of challenges, I think, more challenges than we've ever experienced with,
Indeed, those who are interested in the reactogenicity of vaccines and tune into our previous webinar on this topic. That's a very important question. Now, you did answer my question about which one is worse, flu or COVID. So let's not go through it anymore. My next question is from the queue before I turn it over to Dr. Wax, is what is the efficacy of flu vaccines usually? We've been hearing 90-95% on the SARS-CoV-2 vaccines. What is it for usually for flu historically, just for a point of reference? Thank you.
Yeah, thanks for that. Yeah, so you got to look over many, many different years, and effectiveness is really going to vary depending upon how good a match we have between the circulating influenza viruses and the vaccine viruses. So we typically say about 40 to 60%, and I think over the last number of years is probably around 40 to 50% effectiveness. There are clearly studies that have shown that influenza vaccination can reduce the risk of hospitalization and in kids reduce the risk of death compared to not being vaccinated. So, I would say moderate effectiveness, 40 to 60%. Sometimes we have much lower effectiveness. Influenza viruses are evolving all the time, and they appear to evolve much more rapidly than coronaviruses. So we've heard by press release that the Pfizer and the Moderna vaccines, their phase 3 studies have shown greater than 90% efficacy. But please note that that is after that's 1 or 2 weeks after the second dose. So that's really good news. But the real question is, what is the efficacy, or in the real world, what is the effectiveness, over 3 to 6 months after vaccination? How long is protection lasting, and does it suddenly drop over time? We know that influenza vaccine effectiveness does decline over a number of months. Will that happen with SARS-CoV-2 vaccines? I think time will tell, but at least the preliminary information about the very high efficacy, again, it's very soon after the second dose. I mean, that's really promising, but it's likely that that greater than 90% efficacy is a lot higher than actually what it's going to be in the real world and over a number of months after vaccination.
Thank you, Dr. Ulecki. I would like to turn it over to Dr. Wax. I'm sure there are a lot of questions we won't get to today, so we will make sure we provide them to you in case you want to respond to them, or somebody in your division would want to, target some messaging based on these questions. Dr. Wax?
Yes, and thank you very much for an outstanding presentation and a great Q&A. Just a couple final questions. The first one goes back to this efficacy issue. So let's be optimistic and assume that the vaccine has 90 to 95% efficacy. Does that mean that other 5 or 10% don't develop an immune response? And are those people, and 5% of the population is a lot of people, are those people going to remain at high risk for the COVID-19?
I mean, that's a great question. I don't think I can answer that. When you vaccinate a population, including people who are at high risk for severe disease, you're going to get a range of immune responses. And, what people are looking at is what you really want to know is, does it work or not? But we want to also look at the antibody response. But that's not the only question. And so the other is the cellular immune response. And so it's possible that, those people are not immune at all and are susceptible. It's also possible that people who appear to have been protected in that short period, maybe that they're going to be susceptible in a month. So I don't think we really, first of all, nothing's been published. There's been publication by press release. So we need to see data. And in particular, we need to see data much further out than 1 or 2 weeks after the second dose. So it's a great question. I don't think I can answer that.
Okay, yeah, I look, particularly as the holidays approach this coming week, and many families are not able to get together. In a year from now, particularly in the more vulnerable and the elderly population, if they don't mount the immune response, will they remain at this high risk, that they're presently at?
It's a great question. And so I think the first objective is to get vaccine out, vaccinate the tier 1, tier 2, get healthcare personnel vaccinated, get high-risk people vaccinated, essential workers, so forth. But the question you're getting at is, say, a year from now, what's the situation? Well, if we look at the experience from at least influenza vaccination, we know that antibodies wane over time, really decline, effectiveness declines. It is possible that this can happen as well. The unknown factor is how SARS-CoV-2 is going to evolve. And so if at some point, it's likely that these viruses will start evolving away. What we don't know is, antigenically, will that be significant? So that, will there need to be an annual fall vaccination program, for example, if this evolves from a pandemic virus where we have to worry about it all year round? Is it going to be a more seasonal fall-winter virus? We don't know that, but there are 4 human coronaviruses, 2 alpha and 2 beta coronaviruses that are more seasonal viruses, fall-winter viruses. We don't know, if this virus is going to go that route, but let's say it does, then it's possible, it's unknown, but it is possible that this might end up being an annual fall vaccination program. So maybe you'll need both influenza vaccination and SARS-CoV-2 vaccination, and especially those who are at high risk, but also healthcare personnel, in order to boost the immune response and protect people, but also to get at the issue of if there is antigenic evolution of the viruses where you need to update the vaccine strains. So I think all of this is, too hard to predict now. The first objective is let's just get as much vaccine out right now as we can. Hopefully it's going to have high effectiveness as the early data are showing, and let's go from there. So I think a year from now, we're still going to be worrying a lot about SARS-CoV-2, even if there's a lot of Americans that are vaccinated. But what's going to happen thereafter, I think is, we can all speculate.
Dr. Wax, did we lose your audio? Okay, well, thanks again, Dr. Uwicki, for an outstanding presentation. Thank you, Ms. Lever, for outstanding moderating of this Q&A. We will share with you the Q&A, Dr. Uwicki, so you can look at them as well. And thank you again for your time and patience. We want to thank all our participants for staying over the hour. Everything will be available as a recording. The PDF of the slides are there. Again, the website CDC has many resources that you can review. And want to invite you to our webinar on December 9th, which will be first of our safe disinfectant use series that we're organizing. This one will be on disinfection and sterilization, a primer with a focus on use in healthcare facilities. This is going to be a detailed description of what disinfection is and sterilization processes, what are the chemicals used. It's going to be like a primer that will lay a foundation for our mini series on this topic. Next slide. And then on December 9th, we are tackling the topic of, December 16th, we are tackling the topic of pregnancy during COVID-19 with Dr. Denise Jameson, the chair of OBGYN at Emory University. Next slide. And again, all of our previous webinars, as well as our upcoming ones, are in our prospectus on our website. You can download that PDF and click on the specific topic and go directly to the webinar recording. Thanks, everyone. Have a safe holiday. Next week, we will not be meeting. Please be safe, maintain social distancing, and wear the mask, and keep your hand hygiene. And hopefully next year, we'll celebrate the holiday in a much safer environment. Thanks again.